Shall we start? Shall we start the session?
Yes, sir.
Yeah. So we'll go with 1 second. I want this to be interactive. Okay. Today I'm Dr. Sai Deepak, consultant pediatric neurologist at Andhra Hospitals. I want to take you through some routine pediatric practice. So you people will be just telling some GTCS, GTCS, everything. So routine common childhood onset seizures in pediatric practice. I want to take through to 3, 4 case scenarios and discuss. Nothing hi-fi, just simple, and I want it to be interactive and more didactic than one-on-one, not than monopoly lecture. Okay. Yeah. Coming to case one, a 4-year-old boy presented to a doctor in drowsy state, that is probably post-ictal, and fever. Parents are tensed and they ask when they present it to you, what will you do next? Anyone? Yes, these are all routine scenarios that you come across. Please answer, unmute and answer.
Check vitals.
Yes, yes. You will check the hemodynamic status. Next, you will stabilize that child, isn't it? So after that, the child became conscious immediately. Okay. Then what will you do? Just answer what will you do in a, so I think majority of them are postgraduates.
Ask history.
Yes, exactly. You should ask for history and then, okay, history. And you should ask what happened exactly. Mother told there is GTCS. Suddenly the child is doing these type of movements. All of a sudden, mother told. Then what will you ask?
Duration
History of fever.
Yes, that is one. Any provoking event like fever or diarrhea, discharge from ear or respiratory infection. And then if fever is present, one important thing you should ask is the fever present prior to the seizure onset or how many hours before? If the seizure is present prior to the onset of the seizure episode, how many hours? Did the fever start yesterday? Today only 6 hours before, 12 hours. Why is that important?
Sudden spike of fever, febrile seizures.
Yeah, febrile seizures. But what is the importance of hours before the onset? For example, if you understand my question, they presented with seizure now. The important thing is when was the fever present? Is it immediately 1 hour before, or the fever is onset of fever is 6 hours before, or since 2 days the child is having fever and suddenly he had seizure today? What is the importance?
febrile seizure,
Yeah, tell.
seizure only within 20, mostly 20, within 24 hours.
Yeah, and one more important thing I want to stress here is
Meningitis.
no. Yeah, that is one thing. High grade fever, meningitis, more often the prolonged sensorium abnormality is one thing. But one important thing is you want to give intermittent prophylaxis, especially in a case of complex partial or complex febrile seizures, isn't it? So in such cases, when will you give that intermittent prophylaxis? If the mother doesn't know that fever occurs only, suddenly half an hour before had fever, next seizure. Usually parents can't give, no. So if there are multiple complex febrile seizures with very small gap between fever onset and seizure, we can consider
Instant.
prophylaxis rather than intermittent, because there is no point of giving intermittent, isn't it? Did you understand this clinical point?
Yes, sir.
So next, one more important thing in any seizure, this is not attributing to febrile illness or febrile seizure. This is being attributed to any seizure. You have to ask whether seizure occurred in awake state or sleep. Why? It's not related to febrile seizure. It's generally related to any seizure disorder. You should particularly ask whether it is provoked by fever, whether it occurred in awake or sleep state, because there are certain entity of pediatric epilepsies that occur in sleep state that we'll discuss later during the course of this session. Okay, so next is you should ask the past history. What all you will ask in the past history?
Any history of similar complaints in the past?
Yeah. And
Family history of similar complaints.
yes, that is next time coming to family history of febrile seizures, especially is important. Okay. Next, developmental history. And is the child is a known case of seizure disorder or having any some sort of epilepsy diagnosed or with febrile seizures complex started on any continuous anti-seizure medicine. That is very important. Why? Because that will predict somewhat the risk of epilepsy beyond 5 years, isn't it? Next, I'm going to see this. Now, this child is 4 years. I want to take you through two case scenarios and discuss how will you manage each of them related to febrile seizures. This is child A presenting with GTCS that lasted for 5 minutes, followed by postictal drowsiness for 20 minutes. There is history of fever. See, what all I mentioned prior, what to ask. This is the scenario I'm giving you, and you should answer next. So, history of fever onset, 12 hours before seizure onset, cough and cold since 2 days. Mother gave 1 dose of paracetamol, and this seizure occurred in awake state while child was playing. This is the first episode. Child is not on any anti-seizure medicine. Family history of febrile seizures in maternal uncle and his son. What is the last one? I couldn't.
Development normal.
Development normal. Okay. Next. So this is one case, and I'm going. This is the second case. GTCS 30 minutes, postictal 20 minutes, fever. Yeah. Second episode, first at 3 years for 2 minutes, advised ASM prophylaxis by local pediatrician. Used to give, but this time they missed it. Family history of febrile seizures in father, one episode, developmentally normal. So, what is the child A diagnosis? What is child B diagnosis? Anyone can answer, please. It's just simple, nothing hi-fi about this.
A. Simple febrile seizures.
Yes.
B. Very status because 30 minutes.
Yes, febrile status. Probably
Febrile status.
febrile status. Okay. Okay. So child A is simple febrile seizure. How will you approach this child?
Look for foci of infection in this child, sir.
Yes. See, yeah, okay, that is good. Examination, you have to do everything. So you have to look for respiratory tract infection, urinary tract infections, anywhere, focus of infection. That is investigation part. So as you people are postgraduates, most of them, you should approach in a systematic manner. What I mean, the history part, a detailed seizure or epilepsy history you have taken. Next, you will come to examination. So examination, you have to do general examination that should concentrate mainly on pallor, any other signs of vitamin deficiencies, most commonly D deficiency, should look for neurocutaneous markers. Anthropometry is important because hand in hand comes with nutrition and complete neurological examination. So you have done all this, everything is normal except pallor. Okay. Next, what will you do? Quick, you should be quick, then we can go through all the scenarios, otherwise it will be late. After examination, you came to a diagnosis, it is simple febrile seizures with some pallor, isn't it? How will you approach next? Won't you do investigations?
Peripheral smear, CBC.
Yes, very good. See everything, like do necessary investigations. Whatever she is telling, it's coming on the screen. So CBC with peripheral smear. Next, you can do iron indices.
Iron studies.
Yes. And anything else required?
Electrolytes.
Is it required in this child? Everything pertaining to child A.
Not necessary.
Febrile seizures. When, okay. CUE, is it required? No need. Unless you are suspecting any source of infection, you can do, isn't it? Serum electrolytes, no need. Less than 1 year, calcium can be indicated. You can do. Since this child is 4 years, not required. And as Kirtana told, fever workup has indicated to find out source of focus, isn't it? The focus of infection. So everything is suggestive of some iron deficiency. I'm not keeping the lab values and all. It's just a scenario suggesting of mild iron deficiency anemia. Okay. Next, what you want to do? These are very simple things I want to answer so that I can proceed ahead.
Temperature control. Start the child on prophylactic AED, sir.
Okay. Before that,
And start iron in follow-up.
okay. You went way ahead. I want to go even slowly. So, is there any role of EEG and MRI in this child?
No.
Are you sure? Be confident, whatever you answer. You're all
Yes, sir.
PG,
No
sir.
need, no rule.
Not needed.
You're all trainees, sir, or practicing anywhere?
No role of EEG and MRI.
Yes. And so, in simple febrile seizures, there is no role of EEG. Is there any role of MRI?
No.
Routinely not recommended. Only scenario where it can be considered is in children with focal neurological deficits or signs of raised ICP. You can do a CT prior to lumbar puncture. That's a very, if like there will be some examiners who will be asking any remote relative indication, you can say. So how will you treat this child? You will reassure parents. First, you should advise first aid to any child presenting with seizure. All the trainees should keep in mind This is a part of complete management of a epilepsy or seizure. So that parent should be aware how to manage that child during any acute episode at home, because doctors will not be available at the time. So you should explain the first aid, advise them how to use midazolam nasal spray during the episode, and home-based management of fever, and advise them to visit pediatrician whenever they require. One more important thing, iron supplementation should be started because they are mostly associated with increased risk of simple febrile seizures, and iron-rich diet should not be forgotten, okay? And regular follow-up. Is there any role of anti-seizure medicine in this child?
No.
Absolutely no indication in first episode of simple febrile seizures. Okay, now we'll go to second case. Second child, as told earlier, is a febrile status epilepticus, isn't it? So how will you approach this child, second child? Treat as per,
Airway, breathing, circulation.
yes, that is the status epilepticus guidelines. We'll give Loras, and you have in the
Load with
that was loaded on Levipil.
give paracetamol.
Yes, everything, symptomatic management was done, everything was done, and child became conscious after 30 to 40 minutes. Okay, what next?
Investigations.
Always, he became conscious. After consciousness, what will you do?
Neurological
history.
examination.
Yes, you can ask history. Always history. Okay, already mentioned. So you can take a detailed diet history and everything. Okay. Next, look for pallor, vitamin D, neurocutaneous, anthropometry, complete. So after complete examination, you didn't find any focal neurological deficit in this child. Next, how will you investigate this? You will do CBP, you will do CRP, isn't it? Electrolytes?
Fever profile.
Yes, fever profile. Okay, electrolytes. Calcium, magnesium, yes. Blood sugar should be checked. Urine examination. Fever workup. Lumbar puncture, you want to do?
Yes.
Yes. Why? You can consider if the jail is obtended for around 1 hour. So every first episode of this prolonged status febrile, you should consider CNS infection. Okay. Should rule out there is no harm in performing that. It should be done. And is EEG needed in this child?
Yes.
Yes. How do you want to proceed? Why is EEG needed in this child? Is it going to help the management, current management?
Yes.
Yes, how?
To decide where to give prophylaxis anti-epileptic medicine or not.
No, it can, but ideally, the role of EEG in a febrile status is to prognosticate and predict risk of subsequent epilepsy. Because majority of the EEG findings which you find in febrile seizures or febrile status is some postictal slowing of the background. Few epileptiform discharges can be seen, but less likely, hardly a single-digit percentage. Usually they will be normal, but if there are epileptiform discharges, that will increase the subsequent epilepsy risk, isn't it? So that's the reason. When to do? So child presented to your ER, that child B, as I mentioned, as I projected earlier. So after that presentation, child became conscious in 40 minutes. So you want to do EEG then and there, the same day, or what is your protocol? How do you want to do that child?
Once the child stabilizes.
So child got stabilized in 40 minutes. So you shifted to some step down unit or ICU or somewhere. So you want to call an EEG and get it done. Isn't it? So ideally, it should be done after 24 to 48 hours and within the first week. There is a rationale behind it. Can anyone tell? Why? Please give a try. It's a discussion session. Should learn something and go. Why not in the first 24 hours? Because what happens is immediately post ictal state, you will have it is generally slowing.
Drowsiness.
So in that slowing, it is difficult to find out the epileptiform discharges. Some might be missed. So you might not find that. There is no harm in doing in first 24 hours, but ideally you can do it the next day because on a background that is completely slowed, it's difficult to find out the epileptiform discharges. Then you might give it normal EEG. So we advise to get it done 24 hours later, preferably. And why not after 1 week? Why to do within 1 week? The same reason, because this post-ictal slowing, which is present, will usually last for around 5 to 7 days on EEG. So that might disappear. So ideal is to do within 1 week, preferably the next day after presentation. Are you clear with this? Okay. Any MRI role in this child? Yes. Why? This is very important, which trainees should know. Like most of you will read febrile seizures day in and out. What is the role of MRI in febrile seizures? Please, I want anyone to answer. It's a very common
The
topic.
child development is not completed then.
I'm asking in pertinence to this child. I'm asking pertaining to this child. You have febrile status child who gets back to consciousness after 40 minutes, developmentally normal, with history of febrile seizures in the past. Why is MRI important in this child?
For ischemic changes because of this seizure.
No, that seizure lasted for around 5 minutes or 10 minutes. I don't know. Okay. No, it's
For any anatomical abnormalities.
not anatomical. That's the one I want to see. There are three, four reasons why you will see. One is if you are suspecting encephalitis in this child based on LP picture and all, you have to advise MRI with contrast. You will see meningeal enhancement and any viral encephalitis changes. Okay, if they are there. But further child will be having altered sensorium for prolonged period of time. That is one point. Other thing, if there is any focal lesion, structural lesion or intracranial space of brain lesion like neurocystic sarcosis or tuberculoma, you should rule out. That is one thing. One major thing for febrile status is to look for hippocampal abnormalities mainly. Understood? Because prolonged status or prolonged episode of seizure, rather than causing ischemia, febrile seizures are prone to cause hippocampal sclerosis. Understood? So hippocampus become bulky, they become sclerosed, mal-rotated. All these findings can be present. And can anyone answer this? What is the largest study going on related to febrile status? Have you come across this study? Kirtana? Anyone can answer. So have you heard about PEPSTAT study? PEPSTAT study. It's a very large study going on to in febrile status. It is nothing but all the febrile status children are kept in a cohort, and their cognitive outcomes, their personal persistent changes in the MRI, usually hippocampal changes, and their predilection to cause mesial temporal sclerosis and epilepsy. So temporal lobe epilepsy in future. This is one high risk. Either the percentage is low, but it's a very big risk one, because temporal lobe epilepsy is one epilepsy that could develop in febrile status. Just keep it in mind. Okay. Understood? Can I go on to next one? Further course, this child is in hospital, no further seizures, no fever after 2 days. So will you start anti-epileptic in this drug, in this child? Yes, you will start. The sodium valproate
Yes.
or phenobarbital or primidone. These are the ideal antibiotics, anti-epileptics. Okay. Next, what are the indications for continuous prophylaxis? Febrile status, febrile seizures in children with neurodevelopmental delay, global developmental delay child, autistic spectrum disorder children, frequent complex febrile seizures, and children with febrile status, febrile seizures plus and Jeff's plus with febrile syndrome. Understood? And how long you will give? You will give for a duration of 2 years seizure freedom period. Understood? Last, some patients can ask, or someone can ask, is there any role of genetic testing in this chain? Absolutely no role. Then when you can do genetic testing, and what is that in case of recurrent febrile and afebrile seizures, and even after 6 years with positive family history, developmental regression, new types of seizures, and family history of Dravet syndrome, you can advise whole exome sequencing for channelopathies. So this is the comprehensive what we have discussed. The simple febrile seizures, complex. When can EEG be done? What are the investigations required? You can just take a screenshot of this with the IAP guidelines. Understood? This is the approach. That's what we have discussed on case basis. Did you understand? Any doubts in these flowcharts? You are open to ask. If there are no questions, I'll go on to second case. I hope everyone is clear. Just tell yes or no. That would be
Clear, sir.
yeah. So all are answering in message. Okay, okay. Good, good, good. You can open, just you can tell by voice. I couldn't see all the replies. So just you can. Okay, case 2. 7-year-old boy, normal birth developmental history, negative family history, had second episode of seizure. This is a common thing which you encounter, but you don't know that this is this condition. In sleep, in the form of sudden left side deviation of face, twitching movements of angle of mouth for 5 minutes, followed by post-ictal drowsiness for 10 minutes. Similar episode 6 months back that lasted for 2 minutes. Is it enough? You want to start treatment? What additional history you want to ask? How will you proceed?
Any autonomic features?
Excellent. Any autonomic features are there like? Still, be quick so that we can go quickly.
Whether the child was on any anti-seizure medications.
Okay, already on any anti-seizure medication. Okay, someone is answering fever before seizure. Yes, very good. Provoking event you should ask. And what else? So, an extended semiology history regarding seizure is very essential. Like, is there drooling of saliva? This child had. Is there hypersalivation? Yes. Is there tingling sensation over the face? The child was unsure for that. And one more thing is gurgling sounds you could hear or not while the child was seizing in sleep. And autonomic disturbances. Since the child is in sleep, you cannot ask visual aura or any oral symptoms that could give a clue towards occipital lobe epilepsy. So any provoking event like fever, there is no such event in this child. So it's unprovoked seizure. What else you will ask? Anyone pertaining to this child? Nobody is answering this question. Why? Only febrile
Development is normal.
development is normal. Yes. I already mentioned in the case only, I already mentioned developmental history normal, family history is negative. This is the second episode. What will you ask? I am not asking diagnosis. Someone gave.
Semiology of seizures in the past.
Child is in sleep, so you can't ask about awareness. Child is in sleep. Similar semiology or similar in the past. Yeah, it's already there now. This is a second event. Similar episode 6 months back. Is currently 7 years. So someone is answering Bex. So if you are thinking Bex, what other history you should ask? Any medicine or drug consumed? No, not there. We didn't consume anything. Parents are very caring. They now never keep anything in front of the child. No such history was given. Someone told Bex. So what history you want to ask to confirm that? You should ask this history. Understood? Recent change in behavior, language decline, cognition decline in terms of scholastic performance. Understood? No seizure in awake state. How to proceed further? Please, how will you proceed further? Other than 1 or 2 notes.
Examination.
Yes, examination, normal. So examination completely was done. It is normal. Went ahead with investigations.
And investigation.
So
EEG.
electrolytes, calcium, everything was done. Everything is normal. Is EEG required in this child?
Yes.
Yes, this is
Yes,
the
sir.
second unprovoked seizure. So EEG is required.
Yes, sir.
And you advise for an EEG. Anything you want to mention? See, these are all clinical scenarios. Learning theory is different. Approaching a case clinically is different.
Sleep EEG.
You will ask that thing. Tell.
Sleep
Both
EEG.
awake and sleep EEG.
Yes, awake and sleep EEG is essential. Since this child is 7 years, they are cooperative, they will stay awake, and you have to induce sleep. So ideally, a sleep deprivation the day before helps. So how many of you are acquainted with EEG, like in your hospitals, you will be having EEG, no, everywhere, isn't it? Hmm? So how many
Yes,
of you
sir.
will tell sleep deprivation are all practicing that habit? Yes or no? Please tell couple of you.
No, sir.
So that is important. Sleep deprivation will increase the yield of EEG. So I want you to learn some clinical points. Okay. So sleep deprivation is very important, along with some maneuvers like eye opening, eye closure that will give very good posterior dominant rhythm. I'll tell you later. So this is the EEG. This is the awake EEG, relatively normal other than few discharges here and there. If you see sleep, if you see this temporal region, parietal region, you saw this now? Such things, they are all spikes, spike wave discharges with phase reversals, you call them. That is, phase reversal is something EEG related. So in sleep, you got the abnormality. So that's the importance of sleep EEG. So only a pediatrician or a pediatric neurology trained person can come suspect this and come to this diagnosis. Usually, when adults are being done EEGs or anything, they usually do awake EEG. So how many of you are doing sleep EEGs in your medical colleges or hospitals, wherever you are practicing? Are everyone doing sleep EEG in child?
Yes, sir.
Yes, sir.
So you got this EEG done. So what is the diagnosis? So you had this history, and what is the diagnosis? Tell now.
Bix.
So is it Bex or any other term now? Latest. What is the latest term? Anyone? So it's called, according to latest ILAE classification, it is called SELEC, self-lifting epilepsy of centrotemporal spikes. Previously, it is termed as Bex. It's benign, B for benign. Now it's not benign. Why it's not benign? I'll come later. It's also called Rolandic epilepsy. Why? Because the centrotemporal region is in the Rolandic area. That will cause that, because the spikes or abnormal electrical activities coming in that region, you are having this paresthesia or tingling sensations over the face, speech arrest, gurgling sounds, and only oromotor involvement predominantly. This can secondarily generalize and cause GTCS. Understood? So onset of seizure is very important when you take a detailed history. Is it clear? So usually most of the people will tell, sir, GTCS came, GTCS came, GTCS. So that's why a history by you asking the parents who has witnessed the episode is very important. If nobody has witnessed, no one can do anything. Only investigation is there. Is there need for MRI in this child? See, I'm asking such simple questions. Yes or no? Anything goes well in this child?
No.
Yes, sir.
So ideally not required, but it's better to get an MRI done. It's better to get an MRI done. Why? Who has told us? Kirtana. Tell why.
So to rule out any other space occupying lesion also, sir, in these children.
Or any cortical malformations that can present in this age. So that should not be missed because these are focal onset seizures. Understood? Because these seizures are focal onset, you should not miss the focal seizures causes, like as she mentioned, space occupying lesions or cortical dysplasias, focal cortical dysplasia. Next, should you, so after this, do we want to treat this child? If yes, what anti-seizure medication and duration of treatment? First, you want to treat, yes or no?
Yes, sir.
Yes.
Why? These are self-limiting only.
As the
Can
as there
register.
is continuous centrotemporal discharges,
What? Tell,
we
yeah.
need, as there is continuous centrotemporal discharges, we need to treat
And this is the second episode. Understood the
second episode.
important answer I am expecting. Okay. So second episode, it's better to treat because they can worsen. I'll show what are the possibilities. The sodium valproate, oxcarbazepine, levetiracetam can be chosen. For 2 years, seizure freedom period. Is this enough? What else you want to advise in this child? Apart from basic first aid, baseline cognition scales. So you should involve developmental pediatrician also, and you should get a baseline cognition scales from a psychologist. Regular follow-up, which includes EEG also, and advise parents to monitor for his scholastic performance, major behavioral issues developing anything or like that. Why? Why are these important? You can give an anti-seizure medicine, tell them to go use it, come afterwards. Why is all this important? Hmm?
Whether it is only Bexo or is there any underlying epileptic disorders in this child?
Already MRI is done, EEG is done, it's Bex only. You came to a diagnosis, it is self-limiting epilepsy of centrotemporal spikes. Why all these? Because these are part of the disease you are doing cognition-based assessment. Because some of them can worsen. Okay. If you see this slide, these are the self-limiting epilepsies, that is benign epilepsies in childhood. I just went through selects. Someone mentioned autonomic disturbances. So that is CELIAS, previously called Paediatric syndrome. That is early onset occipital lobe epilepsy. One more thing is COVE. This is Gustav syndrome. This is late onset occipital lobe epilepsy or any lesional focal epilepsies. That means pachymetropsychiatria complex. These are the cortical malformations. So these are all self-limiting epilepsies that can progress. They usually subside by adolescence on itself. You need to control seizures by them. But some of them can worsen. The EEG can worsen and they can develop this cognition, behavior, regression, autistic futures, motor disturbances, all those. Then they go into epileptic encephalopathy like CSWS. This is previously called CSWS. Now it is called ESWAS. This is continuous spike wave discharges in sleep. Or Landau-Kleffner syndrome. This is language aphasia will happen in this one. So these are the extreme ends that a Rolandic epilepsy can progress into. So you have to monitor that one. And there are some oxcarbazepine is one drug which is most commonly prescribed. As here, oxcarbazepine is most commonly prescribed. But the thing is, sometimes there can be worsening on oxcarbazepine and they can turn into generalization on EEG. So these discharges are seen only in sleep and they are seen like this. See the awake state, how nicely it is, other than some faster components here. Can you see my pointer cursor? Can you see? Can you see my cursor? Okay. So these are the generalizations. This same child, Beck's child, after few years turned like this. He presented with cognition and autistic futures. he has these generalization discharges. That is CSWS. Understood? So these four are the benign epilepsies of childhood that are not benign actually. They can turn into this condition. That is the important point I want to stress. And self-limited epilepsy, this is based on age of onset. Understood? So these are the epilepsy syndromes one need to be aware of. Is it clear? Okay. Okay. What is the prognosis? They resolve completely by puberty or by adolescence in majority. Can convert to DEE in very few, but it's a bit severe. Hence, monitoring and regular pediatric neurologist follow-up advised. Any doubts in this case? Any doubts? Can I go to third case? Last
Yes,
case.
sir.
Yes. Did you find it interesting till now, or is it boring?
In case of Rolandic epilepsy, how many anti-epileptic drug may need, sir?
Ideally speaking, if it is first episode of Rolandic epilepsy that lasted for very 2 minutes or 5 minutes, ideally speaking, you don't require any anti-epileptic. Okay, since this occur in sleep, it occurred in sleep, not in daytime. So ideally not required. But the thing is, there is high chance that another 2-3 episodes will occur and patients are very anxious. Usually one anti-epileptic will control it well. And my clinical experience with sodium valproate is excellent, and most of them, other than 1 or 2 seizures or maximum 3, they won't get further. I didn't require 2 epileptics unless they go into, as I mentioned, 1 second, I'll go to this EEG. This entity is there, no, DEE or epileptic encephalopathy. If they go into this spectrum, they require multiple AEDs. I will go for sodium valproate, clobazam, or clonazepam. These are the anti-epileptics I would prefer. But in classical Rolandic epilepsy alone, one anti-epileptic is more than enough. Oxcarbazepine is good enough, but valproate is superior to oxcarbazepine according to current guidelines. If they have multiple seizures, then you obviously require second anti-epileptic. Then if they have multiple, they go into DEE, you have to think of some genetic causes as well. There are something called GRIN, GRIN2A mutations that need to be considered if they go into DEE. Okay, you are clear?
Yes, sir. Thank you.
Can I go for third case? Any other question? All right, I'll go with the third one. So it's the last case, very short case, but very important case that one should not miss. Okay, because very easily treatable and very good outcome. So 8-year-old girl with normal birth and developmental history, negative family history, with multiple episodes of sudden brief loss of awareness, and unresponsive and behavioral errors, and she gives a blank stare, blank stare. She suddenly stops the activity completely and then resumes. Very brief. She does around 20 times per day. How do you classify this seizure? Very simple question. Quick. Someone answered.
Absence seizures.
Yes, absent seizures. Excellent. Okay, so how would you differentiate? I would say this is focal seizure. How would you differentiate it from focal seizure? See, if you see ILA classification, you have focal aware and focal unaware, isn't it? So it could be focal unaware. Why not? Why is it not focal? Anyone, just quickly, so that I just go through. See, the reason is focal seizures, they will be for even longer duration usually. Ideally, EEG only differentiates both of them. You can do differentiate bedside also. Symptomatic history-wise, focal seizures last even longer time. Options are very brief, 1 to 2 seconds. And usually there will be no aura, there will no postictal state. And options, one important history is multiple episodes in a day, unlike focal. Focal and raw, that many episodes don't come in a day. So these are multiple, 20 are very less. Some have 30, 40 episodes also. And no memory of even during the episode. No eye. And one important history you should ask in this child, is there any eyelid fluttering? Because there is one entity called eyelid myoclonia that need to be found out. That is also a part of generalized epilepsy. No clonic-tonic movements. How will you confirm clinically? So you are thinking childhood absent epilepsy. How will you confirm clinically? Is there any test you want to do?
Hyperventilation EEG.
No, bedside also you can perform. Before EEG, you can do hyperventilation test bedside. How will you do? So you should some very thin rim of paper, like I'm just on paper you have to keep in front of the mouth. You could see me, no? And you should ask the child to stay straight. She should do some deep breathing that will cause CO2 accumulation. Sorry, watch out. And they have to, that patient has to do that, and you can better record it. You will find some absence episodes that can be recorded. Understood? And as already mentioned, EEG that should include, just for as Rolandic epilepsy, you advise the sleep EEG. You should compulsorily do hyperventilation maneuver while doing EEG. This is normal awake in that child. When doing hyperventilation, look at the generalized discharges. So this, can you see my cursor? Just say yes or no.
Yes.
Yeah. So this thin line is 1 second in an EEG. This is another line. Between these two, it is 1 second. Between these two, it is 1 second. So from this line to this line, if you see 1, 2, 3, there are 3 hertz. You call it hertz. Generalized discharges. 3 hertz spike. You call that one. Understood? So 3 per second. That is the basically this thing for absence. If it is a typical absence, it will last 2.5 to 2.5 hertz or 4 hertz. That is the difference. This is classical absence seizures. Understood? How will you treat this child? Understood? Valproate or ethosuximide. That is superior to your lamotrigine. Understood? So how much dose you will give valproate? 13. Okay. And usually, as both combination of these two drugs will give better outcome clinically rather than valproate alone. I think you can start with valproate. Even if the number of episodes are not satisfactorily coming down, you can add ethosuximide also. Only thing you have to keep in mind, some GI side effects like gastritis, some abdominal pain, some non-GI side effects will be there with ethosuximide. Understood? They usually have good prognosis. Some of them can develop into juvenile absence epilepsy. These are completely by adolescence. One important thing, see, treatment everybody will give, but the management includes patient counseling and first aid. So advise not to do driving, cycling or swimming until full control of seizures is achieved. Understood? Screen for coexisting poor scholastic performance or ADHD, such conditions. So we are completing today's session. So four routinely encountered pediatric childhood onset seizures. One, simple febrile. We started with simple febrile. We went ahead with febrile status, what are the management controversies or approach. Next, common pediatric epilepsy, that is Rolandic epilepsy and childhood absence epilepsy. I think I have done justice with this. What about Levira? For which one? Levira for which one you are asking? Someone asked. No, Levira, see, low dose of levetiracetam can be tried only if it is not controlled on these first line drugs. Understood? Even literature mentions Levira. It is useful only, but it's not highly efficacious as far as I'm concerned. Like Levira is not the first line drug. It's only valproate, ethosuximide, or lamotrigine can be tried. But levetiracetam, low dose levetiracetam will cut down some amount of absences, but complete recovery, I'm not. It can be add-on drug, but not the first line drug. That's what I can say. Is it okay? Sure. So, thorough history taking is essential to classify the seizure type. Then you can advise EEG properly, and always to all the trainees or any practitioners, give importance to skin examination in neurology. Because though the cases which I'm not discussing are skin related, but you can get most clues, especially vitamin related epilepsies or some neurocutaneous syndromes. Electroclinical diagnosis is very essential in choosing appropriate anti-seizure medicine and helps in prognosticating. Sleep is essential in pediatric. Sleep EEG is essential in pediatric epilepsy diagnosis and management. Activation procedures like sleep, eye open and close, hyperventilation, photic stimulation are very essential in classification of pediatric epilepsy. Parent education in managing a seizure episode is an important part of comprehensive epilepsy management. I'm sure you will all learn from this session. Thank you.
Thank you, sir.
So any questions you have?
Excuse me, sir. I just wanted to clarify what is the relation of onset of fever in relation to the onset of fever. You explained, I think.
What I didn't get you? Onset of
Relation of onset of fever in relation to the onset of fever.
see,
in the
only rationale here is regarding intermittent prophylaxis. The thing is, a child presented with febrile seizure now. This is the second episode presented now. So this is our third episode. The problem here is you are giving intermittent prophylaxis. Understood? So intermittent
Yes, sir.
prophylaxis means at the time of onset of fever, they have to give paracetamol, tepid sponging, all those. Along with that, they have to give some clobazam or benzodiazepine, isn't it? If the
Yes.
fever occurs 1 hour, like immediately, and the seizure occurs, usually clinically in real-time scenarios, parents doesn't have enough time to start this benzodiazepine. So if multiple such episodes occur where the fever occurs immediately and then the seizure occurs, then if there are multiple such episodes, it's better to start continuous prophylaxis rather than intermittent prophylaxis.
Thank you.
See,
And
the child, for example, fever came today evening. He had seizure tomorrow morning. So there is ample time. So parents can give that intermittent prophylaxis at the same time. So they had enough time. So they are like, fever came now. So they'll give fever medication along with this one. Again, tomorrow also they will give. That could help. Otherwise, there is no role of intermittent prophylaxis.
one more doubt I have. To call it a febrile seizure, should there be fever, or should the seizures occur at the height of fever spike, or even if the fever is present 1 hour prior and then seizures occur 1 hour after the fever, is it okay?
Yeah, this is a big question where everyone are not sure about that, because the thing comes before presenting to us that if that event occurs at their home. So parents will tell, "Ollu kaaltundi, heddi tala kaaltundi," they'll tell something else. So many of them doesn't have a documented this thing. So we are not sure whether the fever is present from 2 hours before or not. So what I do clinically, like on my experience, what I do is, if even after admission, the fever spikes, so immediately at the time of admission, the child can be having fever. That can start 1 hour prior or at the time of seizure also. So if the fever spikes are persisting, like even after admission or even after the seizure, then I would consider it could be mostly a fever provoked seizure only. And one more history that could add on is any antecedent or prior cough, cold associated thing is there. Then that could be the course of illness, right? Cough, cold will come, next fever will come. So that can be persisting even after the seizure. So that's where your decision making should occur. One cannot clearly delineate that is it that fever is due to that seizure activity, motor activity, or just started prior to that seizure fever. Understood?
Okay, thank you.